Good morning. Today's topic of the presentation will be oral and maxillofacial radiography. There are two types of radiography which are intraoral and extraoral. Intraoral is that where the image receptor is placed inside the mouth of the patient, and extraoral radiography is that where the image receptor is placed outside the mouth of the patient. Here we come with the intraoral radiography. It is mainly of three types: periapical, bitewing and occlusal. Description of a radiographic technique, which includes the patient position, placement of the image receptor, direction of the central ray, point of entry or the centering point, and exposure parameters like the tube voltage, tube current, exposure time, and etc. General considerations which we consider in intraoral radiography, where the film is placed inside the mouth of the patient, is that we follow the infection control protocol. We follow the methods of radiation protection, which we provide a leaded apron to every patient irrespective of age and sex. Prior and careful explanation of the procedure will make the patient relaxed, comfortable, confident of your ability, and therefore cooperative with us. Eyeglasses, nose ornaments, and removable dentures should be removed prior to exposure, and we should also immobilize the patient to avoid repeated exposure. General considerations which we carry out the most easier and more comfortable techniques. The film should remain flat as far as possible. Gentle bending should be possible so that it can avoid the tissue injury and gagging. Process under standardized conditions to achieve consistent good quality of the radiograph. We should interpret under ideal viewing conditions to obtain maximum useful information. Intraoral periapical projection. It is mainly to record the images of teeth periapically and also the periodontal alveolar bone. There are two techniques which we call as the one as paralleling cone technique or the long cone technique and bisecting angle technique or short cone technique. Paralleling cone technique or of the intraoral periapical radiography, we generally consider the two conditions like the patient position and placement of the image receptor. This technique was first described by Edmund C. Kells in 1896. It was revived by Donald McCormack in 1937, and it was perfected by Gordon Fitzgerald in 1947. Placement of the image receptor. The image receptor should be positioned parallel to the long axis of the tooth to be radiographed. Special devices, which are the receptor holders, they should be used to achieve and maintain the correct receptor position. This pictorial representation, it represents the placement of the image receptor of the tooth. It should be parallel to the long axis of the tooth. Requirements for receptor holders: it should be rigid, it should be autoclavable, it should be light and small, it should maintain parallelism between tooth and the receptor, and it should align the central ray perpendicular to the receptor. There are three types of receptor holders, mainly the artery forceps with a bite block, the snap A ray instrument, and XCP device. This is a picture of the snap A ray instrument which we use in paralleling cone technique. This pictorial representation is mainly the XCP instrument, which is also known as the extension cone paralleling instrument. And this is the artery forceps or the needle holder with which we hold the X-ray film. Direction of the central ray is one of the important consideration which we consider in the paralleling cone technique. The central ray should be perpendicular to both the image receptor and also the long axis of the tooth in also the vertical and horizontal plane. In both the planes, it should be perpendicular to the image receptor. Point of entry or the centering point. Maxillary and mandibular teeth, there are two different considerations in both of the jaws. In maxillary teeth, it should be along the elatragus line, and in mandibular teeth, it should be along a line 3 cm above the inferior border of mandible. Exposure parameters should also be taken care of, which includes the kVp or the tube voltage. It should be 80/65, and the milliampere or the current, the tube head current. Exposure time should also be different for maxillary anterior teeth, posterior, and also mandibular front and posterior teeth. Advantages of the paralleling cone technique: mainly better image quality is obtained, sharper image with least image size and shape distortion. Detection of the early caries at the DEJ junction. It also provides a better access. Detection of early periodontal disease possible due to perfect superimposition of buccal alveolar crest over the lingual alveolar crest, and this technique avoids the superimposition of zygomatic process of maxilla over the periapical region of maxillary molar. Advantages related to the patient protection. It also provides less radiation due to higher kVp or the tube voltage, more TID and less vertical angulation, and patient is also positioned in a reclining position. Advantages in general, the technique can be executed in any patient position. Limitations of the paralleling cone technique. Difficult to master, difficult to practice in endodontics, needs special receptor holders. Thank you.